Okay, now I'm going to show you how we're going to do our baby assessment. Now, what we're going to do here today is the initial baby assessment that comes right after the baby is born. And in this scenario, the baby is going to be handed to me and I'm going to place the baby on the warmer and I'm going to do my assessment on the warmer because it's easier for you to see what's happening. In real life, the baby should go right from the birth canal to the mother's abdomen, skin to skin, and almost all of my assessment can be done on the mother's abdomen. But it is difficult to see that way, for you to see me, and it's going to be difficult for me to see you. So we're going to do it this way for now, okay? At home, you do not need to have a warmer. You can just do your baby assessment on a table, on a bed. And again, if you have a baby doll, that's great. If you have a teddy bear, that's great. If you don't, just use a pillow and designate one part as the head and one part as the legs, okay? Again, just like in our postpartum assessment, we don't have to have this memorized, okay? The baby assessment is pretty detailed, and so there's a lot of pieces to it. We're gonna go head to toe, and that's gonna help us, but we might still forget some things. And so I'm using, these are my cards here, okay? Just to help me know. And these are some examples of other cards that students have done, okay? And so you can see there's lots of ways that people have done them. Some people put a lot of information on a card. Some people don't put very much information on a card. It's just a way to cue you so that you can look at the end and see what you've done, okay? Okay, so in our scenario here, Mom is getting ready to deliver. We have our warmer on. We have our blankets out here pre-warmed because the most important thing for our baby is going to be thermal regulation. And so I think I hear her pushing. Here comes our baby. Congratulations, Noel. Look, thank you so much. I'm going to bring him to the warmer and I'm going to dry off his head. Get him all dry that way. Then I'm going to lift him up and get rid of those wet linens, okay, so that I can finish my assessment. Now, you'll notice that I have side rails here. I'm gonna put this back down so that you guys can see the assessment better, but know that safety is important for newborns too, and we don't think about it, but they can also roll off of a table, okay? And so we wanna make sure that we're safe when we do our assessment. Okay, so the first thing we want to do, we're dry, and I notice right away that the baby is screaming and that his color is pink and that he's vigorous. He's moving his arms and legs. So that tells me something already, knowing that the heart rate is going to be above 100, probably, okay, and that his respirations are good. But still, we're going to do all those things. We're going to assess all those things to make sure. Now, the first thing my mom and dad want to know is how much does my baby weigh? Well, first they say, is he all right? Is he all right? And I'm going to say, he's beautiful. He's beautiful. And they say, does he have all his fingers and toes? How much does he weigh? And so we're going to put a blanket on our scale and then zero it out. And then we're going to weigh our baby. And we want to get our weight in both pounds and ounces because that's what mom and dad care about. But we also want to get our weight in kilograms because that's what we care about for doing our ballot exam. Now, this scale right here doesn't have a length measurement on it, but many scales do. And so that's one way to do the baby's length is to put his head up to the end here and then to pull his little heel down or straighten out his leg and look at where his foot turns out. There are some other ways to do it though. I could take a pen and mark here and then pull his leg out here and then I could measure where I marked. And again, mom and dad care about inches, we care about centimeters. Or I could do it really the old-fashioned way, and I could go from head to rump, and from rump to heel, and get my measurement that way, okay? Now, there are a couple other places that I need to measure, and I'm just gonna go ahead and do those while I have my measuring tape out. But you can put those somewhere else in your assessment. We're gonna measure the baby's head circumference, right above the brow. Again, in inches and in centimeters. Then we're going to come down here and measure the baby's chest circumference. Right over the breast buds. We want to be consistent where we're measuring things so that if there's changes when somebody else does an assessment, we know that we're all measuring in the same place. And then I'm going to come down here to the biggest part of the belly, the abdomen, and again, in inches and in centimeters. okay? And that's all for my measurements. The other part of my vitals, and I should have cleaned my stethoscope already. Our heart rate. And now I'm going to listen, and this is a baby. And so babies have irregular heart rates, especially when they're first born, so I'm going to listen for a whole minute and get my heart rate there. If other people around me, other practitioners, want to know what the heart rate is, I can actually help out a little bit by moving my finger like this to let other people know what the heart rate is. And believe it or not, right after birth, you can just palpate the umbilical cord and you can count your heart rate that way as well. I'm here, now I'm going to listen for respirations. And I've got my hand here to feel for respirations, and I'm using my eyes to visualize respirations. These babies have heart rates that are really fast, 110 to 160, and respirations that are really fast, 30 to 60. And so it helps to have all of my senses looking at respirations. So that's my weight, my length, my circumferences, my heart rate, my respirations. I've got my stethoscope on. I'm just going to go ahead and listen to the abdomen so I don't have to worry about my stethoscope later on. And yeah, babies have vowel sounds, just like we do. And again, while I've got my stethoscope on, I'm going to listen to the back for the lung sounds. It's very common to hear some wetness in those lung sounds because remember, up until a few moments ago, my baby was inside and his lungs were filled with water, and it takes them a while to get rid of all that. It takes C-section babies a little bit longer. Okay, so I've done all of my vital signs except for a temperature. I would do an axillary temperature. Many places still do one rectal temperature, but after that we shouldn't do any rectal temperatures at all because we can damage tissue down there. So I would do an axillary temperature. And then our fifth vital sign is pain, and you would say, we can't really tell if a baby's in pain. You can. Your institutions have scales to help you assess if a baby is in pain, and I'll tell you that as you work with babies, you get used to hearing a normal baby cry, a distressed baby cry, and a baby in pain's cry. Mothers learn this. One of the first things they learn when they bring their babies home is, what does that cry mean? Okay, so that's all of my vital signs. Okay, on your checkoff, all of the skins in the skin assessment and the reflexes are on the front page, and so I'm going to do it in that order. But again, you can intersperse those if you would like into the systems, and that would be fine. Let's just make sure I get them all. Okay, so I'm looking at the color of my baby's skin. It should be consistent with his genetic background. I'm looking at the texture of the skin and the turgor. Now, it's hard to test a baby's turgor like we test our turgor. If anybody's ever felt a newborn baby, their skin is so smooth and moist. It's beautiful, really, right? Sweet as a baby's butt, they say, okay? But in our preterm babies, their skin is actually very, very thin and almost sticky, and so you can tell the difference, okay? So this is a nice term baby. I'm looking for lanugo, which is hair that hasn't fallen off yet, and I usually see most of it across the back and the arms. I might see some vernix. The vernix is that cheesy coating that kind of like Crisco that covers the baby when he's in utero so he doesn't kind of get all wrinkled up, and they start losing that towards the end. And so for our baby here, who's a term baby, I'm probably going to see that mostly in the skin folds over here. Sometimes people want to rub all that off and make the baby look nice and clean, but that's actually really good for the baby, so we're not going to rub it off. Okay, and then the last thing we're going to look for on the skin is any rashes. Sometimes baby have what's called a Mongolian spot here. It's important for us to document that. We may have a stork bite or some rashes on the face, and so if they're there, we're just going to document them. Okay, so then we're going to go to the reflexes. The first reflex is the Moro reflex. Now, your book gives you a couple ways to do that. We could snap our fingers. We could lift the baby up like this and drop it slightly so that it's scared. But the fact is, if you've ever looked at a bunch of babies, that if you do nothing at all, at some point they just do this. And that's the Moro reflex, okay? So if we'll just pay attention, we'll see that. And we're looking for symmetry. Remember health assessment? So if I have a Moro reflex and one arm comes up and my legs come up, but this arm over here doesn't come up, then I have an asymmetric Moro, and I might wonder if I have a broken clavicle. Okay, so they give us some hints about if we had any injuries. I'm going to look at my blink reflex. Okay. So my baby should blink, and while I'm looking at the blink, I can also look at the pupillary reflex. Okay, same thing. We should have constriction, a little bit harder to see because their eyes are fairly swollen, and once that erythromycin ointment gets in there, it's going to be really hard to see it. Okay, the rooting reflex, if I touch his little cheek like this, okay, so if I'm touching his cheek, he should turn right towards it. Okay, and when he turns right towards it, I can slide my finger in and I can feel the sucking reflex. And while I got my finger there, I might as well feel the top of the mouth to make sure that the hard and the soft palate are in good shape. If I put my fingers in his hands, he should grasp my hand, so that's the palmar reflex. And he should do the same thing with his little toes. His little toes should curl around my fingers as well. Okay, we have that upside down J for the baby, the Babinski reflex. Another reflex that we do with our little babies is the tonic neck, and so let's see, this is a plastic baby, so it's hard for him to do this, okay? But if I turn his head over this way, then his arm should go out this way, and his legs should go out. So kind of like a fencer, so think Olympics. So if my head goes this way, my baby goes like this. If my head goes this way, my baby goes like this, okay? The trunk incurvation, if I put him on his little tummy over here, and I kind of run a finger up one side or the other, then he should turn towards that side, okay? While he's on his tummy here, I should see him do a prone crawl. If you've ever seen a baby kind of scooch up on their own, they kind of shift their butt up and then kind of scooch forward. That's that prone crawl. And while I've got him on his tummy here, I can see that the buttocks are symmetrical, okay? Okay, so now I'm ready to go head to toe. Okay, so I've already measured my head circumference, so I don't need to do that anymore. Okay, when I look at his head, I'm looking for the general shape of his head. I'll post some pictures for you of Professor Kroll's little boy when he was born. He came out sunny, what we call sunny side up, meaning that instead of looking down, he was looking up, and so his head was, he looks like a big cone head. Okay, because all these bones here could kind of roll over each other, and then it's amazing. Within several hours, it all goes back. But I want to see if I feel any of that molding here. If I can feel the anterior and the posterior fontanelle, they should be flat, not bulging or depressed at all. Is there, if we have a lot of molding, if you think about those skull bones going over this way, then I'm going to have some edema with just some extra tissue here, and we call that caput, and that crosses the suture lines. I might also see a big blood blister on one side of the skull or the other. Maybe he had kind of an abnormal presentation and he was really pushing on one part of the pelvis, and so he's got a hematoma over here. Okay, a blood blister is just a collection of blood. That's our hematoma, and it's on his head, so it would be called a cephalohematoma. Okay, those do not cross the suture lines, and they take a little bit longer to resolve. They can take weeks to resolve. Okay, so that's the head. Now looking at his face, I'm going to hold his little face up here so that you guys can see that we don't hold real babies like this when we're doing their face assessment. Okay, so we're looking at symmetry. Are the eyes symmetrical? Is the mouth symmetrical? Did I have any damage here on the cheeks? Okay, are there any marks here? If this baby had been a forceps delivery, the forceps you can think of look like big salad spoons, and they're attached like this. So see where my hands end up? And so sometimes there are lacerations there, or we have a little bit of nerve damage. If the baby had a vacuum delivery, it's like a big suction cup on its head, and so we might see like a big hickey here. Okay, and so my face looks fine. It looks symmetrical. I might notice some little bumps over here called milia. They're just little sebaceous glands, and those are perfectly normal. We don't pop those. Just normal for our baby, and they'll go away. And my baby, I've already looked at the blink reflex and the rooting reflex, so I'm good there. Now coming down to his nose, okay, they're usually pretty smushed in there because he's been smushed inside the birth canal, but I want to make sure that he can breathe out of each nair. Okay, babies are obligate nose breathers, so I really don't even have to close his chin, but if I was worried about doing a good assessment, I could occlude one nair and close the chin, and then do the same thing with the other nair, just to make sure that they're both patent, okay? Coming out here to the ears, I want to make sure that the eyes line up, the outer canthus of the eye lines up with the ear on both sides. If it doesn't, if I have low set ears, It's not diagnostic, but it is a sign that we see often in babies that have chromosomal abnormalities. So I would want to pay attention to other signs I might see. Okay, looking at the ear, I see that it's normally shaped. Okay, when I push the ear here, I can feel cartilage up at the top. And if my baby is term, he should have what we call ready recoil. And you can do this with your own ear. If you take your ear here and you push it forward, and then you let go, it goes back right away. But if I was a preterm baby and I pushed my ear forward like that, it might just stay there, or it might take a long time coming back. So that's going to help me know how old my baby is. And lastly, on the ears, I want to make sure that there actually is meatus there, that there's a canal there for the ears. Okay, the ears form at the same time as the central line organs, like the heart. And so if there's a defect here, it could mean that there's a defect over here on the heart. So sometimes we actually don't have an ear canal, or sometimes we have little tags of extra skin here. And again, not diagnostic, but tells me that something's going on, and I want to make a notation of that and look for other findings so that I can give them to the provider. Okay, so we did the eyes, the nose, the ears, the mouth. We're looking for symmetry. We already checked that rooting reflex and that sucking reflex. And remember, when we put our finger in there, we checked the upper part of the mouth, the palate. So the hard palate and the soft palate should be intact. If there's not, if we have a cleft there or at the lip, the baby's going to have a hard time latching on. Obviously, he's going to need to have the surgeries, but our immediate concern is going to be getting the baby to feed well. Okay. We also want to look at the tongue and make sure that it's freely moving. There is a condition where the frenulum, the bottom part, is short, and the baby has a hard time sticking his tongue out, and that will make nursing a little bit difficult. Okay. And then the other thing for the ears is the hearing test. Now, every baby gets an official hearing test before they go home, where they put a little monitor on him here and look at brain waves to make sure that he's hearing. Okay. But for us, in our assessment, he should recognize his mother's voice. He should recognize his father's voice, or maybe other members of our family. And so if we just pay attention that he turns when he hears his mother talking, that's a good way for us to assess hearing. Okay. Okay, also on the eyes, here we looked at the symmetry of them and the spacing. We looked at the pupillary reflex there. We looked at pupillary constriction. We can also look at the sclera and the corneas. Okay, they will actually come in and use ophthalmoscope and make sure that there's a red reflex. The absence of a red reflex means congenital cataracts. And we can pull down here and look at the conjunctiva and make sure that they look nice and pink as well. Now, within the first hour of life, the baby is supposed to get a dose of erythromycin ointment into each eye, and we do that as a ribbon going from the inside to the outside, and you just really can't see much after that. Because remember I said they're already swollen, and then if we put a bunch of Vaseline ointment in there, then it's going to be hard to see. When we document the eyes, when you think back to health assessment, you use that acronym PERLA, Pupils Equal, Round, Reactive to Light and Accommodation. So we can still use that, except we cannot test accommodation. Right? I can't say to the baby, follow my finger as I go back in here, right? So we can only do pupils equal, round, reactive to light, okay? Okay, so that's our eye assessment. Most babies have dark eyes. Initially, they may change a little bit. And they say their vision is like 200 something. I don't know how you really measure that. But if we think about it, Mother Nature takes care of things, right? Who is the most important person for the baby to be able to see? Their mother. And so right here, when the baby is nursing, that distance there is about how far they can see clearly initially. Okay, so we've done the whole face. Now we're coming down to the neck. And so babies have a pretty short neck. We want to make sure that there's no extranuchal folds over here, which can be another sign of a chromosomal abnormality. We might see some vernix in these creases here. The neck should be freely movable. I worked with an obstetrician once who talked about how really strong they are if you support their neck, and it scared the mothers. He would pick up the babies like this and he would go, look, see how it's fun? Don't you do that. Okay, coming down here, we're going to assess the clavicles. So if you feel your own clavicles going out here, the babies, this is their collarbone, right? If we've had a really difficult birth, sometimes this collarbone or this clavicle gets broken. And so when we feel coming out this way, we're going to feel a little bump, or we're going to notice a bulge there. The other thing that we'll see if the clavicles are not intact is that we have an asymmetrical Moro reflex. Okay, so all those things will come together. Coming down to the chest, We did our respirations, and so when we listened to the lungs and we did our respirations, we noted that the baby was breathing easily. And that's important for us to document, that we have unlabored respirations. A baby that has labored respirations is working very difficult to breathe. And you might see what we call retractions. So instead of a nice smooth up and down, we see a baby that's going like this, using all of its accessory muscles to breathe, okay? We might even hear grunting, which doesn't really sound like a grunt. It sounds kind of more like a, which mom and dad might think is kind of cute, but it's not cute because it tells us that the baby's having a hard time breathing. And if he has to work really hard to breathe, he's going to use up the glucose that he has, and we're going to have a trouble with glucose regulation and thermoregulation. So we don't want our baby to be working too hard to breathe, okay? So unlabored respirations are the norm right there. We listened already when we did our vital signs, and so we know if we have any wetness at all. We listened to our heart when we did our apical pulse. We can listen in those 5 areas just like we do on an adult, okay? We may, in the first couple hours, hear a functional murmur, which is okay, and it may or may not be there every time, okay? But within the first 24 hours, all of those newborn adaptations should be closed, and so we should no longer be hearing a murmur. Okay. If we hear one, we definitely want to document it and let our provider know. Okay, coming down now from, we did the chest and we did the heart. Looking at the breasts itself when we do our Ballard exam, a preterm baby has hardly any chest development, and so the breast is very flat. A term baby has a slight elevation, and actually the nipples are slightly elevated. And we could actually measure those. We could measure those breast buds in millimeters, and that would help us know how old our baby is. Okay. Coming down here to the abdomen, we've already done our abdominal measurement, and we listened for bowel sounds, so we're good to go there. We do want to look at the umbilical cord, the umbilicus. So I want to note that it's got a clamp on it. Initially, so see how babies house umbilical cord here? It's got this Wharton's jelly on it, and it's still moist, okay? And if I put my fingers there, I could actually palpate the heart rate. But as time goes on, the Wharton's jelly is going to constrict, and these vessels are going to stop working. I won't be able to hear the heart rate, and so we would say that it's drying. And the clamp is going to stay on until the cord is dry. And when we send the baby home, we're going to take this clamp off because these vessels will have already closed, and we don't have to worry about that. Thank you very much. Okay, also coming down on the abdomen, we're going to check for our pulses here and make sure that we have no kind of inguinal hernias going along. Okay. Overall, I've been looking at my baby's extremities, so he should be flexed, both arms and legs, and moving around. Okay, I should have 5 fingers, 5 toes, 5 toes, good flexion and symmetry here. When I pick up a real baby, as opposed to a plastic baby, when I pick him up like this, supporting his head, his spine will be C-shaped. It'll have a curve, a natural curve. And I want to make sure that there are no abnormal indentations or tufts of hair that can indicate some kind of problems there. Okay. When I looked at his prone crawl, when I had him on his tummy like this, remember we talked about the symmetry of the buttocks, and so that tells me a little bit about what's going on with his hips. When I'm looking at him from this direction here, okay, if I have a dislocation of the hip, this is going to look abnormal too. Like the buttock folds this way are not going to be symmetrical. And we can do what's called an Ortolani's maneuver, which is very difficult to do on a plastic baby, but that's what tells us whether or not we have a hip dislocation. So I take my hands and I'm supporting the knee, and I'm also supporting the hip joint. Because if my baby has a dislocated hip, I don't want to make it worse, right? And so I'm going to push up and out. And again, this is much easier on a real baby. And come back down, okay? I do it at the same time. Up and out and come back down. If there's a dislocation, I'm going to hear a click, and I'm also going to feel it because I've got my fingers right there. And so I'll know that there's a problem there. Okay. Let's see, I'm ready to do my baby's genitalia. So this is a little girl baby, so I'm looking at the mons and the labia majora and the labia minora and the clitoris. Sometimes we have a little bit of bleeding just because of the mom's hormones, and that's very normal. It's all very small, so we're probably not going to be able to see much in terms of the vagina or the meatus unless we separate the labia. The older the baby is, or the closer to term, the more prominent the labia are and the less prominent the clitoris is. okay? My preterm baby that's like 25 or 26 weeks, going to be the other way around. The clitoris is going to be very prominent, the labia are not going to be prominent at all, okay? With my boy babies, I want to make sure that the urethra is at the tip of the penis instead of the underside, because that, again, hypospadias is a defect. I want to check for the scrotum on both sides and palpate for the testes to be descended. And so again, when I do that, I'm going to put one hand here on at the inguinal area, okay, and then palpate my testes through the scrotum. And I want to know that they've descended or not. They feel like little almonds. If they haven't descended, then I'm going to note that, okay? So somebody can be checking later on to make sure that they have. And the last thing I want to check with a little boy baby on the scrotum is the rugae. So it's the creases that are there. Again, the older the baby is, the closer he is to term, the more creases there will be, the more rugae there will be. The younger the baby is, the smoother the scrotum will be. And those creases happen on our hands and feet too. Okay, the older the baby is, the more creases I have on my hands and my feet. The younger the baby is, the smoother it is. Okay, remember we said too, the chest is flatter. So all those things help us identify how old our baby is. Okay, we already did a temperature, a rectal temp once, or maybe we saw a bowel movement, and so we know that the anus is patent. We looked at the buttocks to make sure that they were symmetrical. And so the last thing is our baby's elimination pattern. So for elimination for voiding, we say at least 1 the first day, 2 the second day, 3 the third day, 4 the fourth day, until we get to a week, and a normal pattern for a baby is to void 6 to 10 times a day, okay? And again, we're not really weighing the diapers unless the baby is ill, but we do want to know that the urine is clear and that it doesn't have an odor. For a bowel movement, the baby first has that meconium bowel movement, which is really, really sticky, black and tarry, hard to clean up, and he'll pass 2 or 3 of those. And then generally after that, his bowel movements should be fairly consistent. So a baby that is breastfeed has very liquid bowel movements that are a pretty kind of yellow colored, and I say have like a sweet smell. Not everybody thinks they smell sweet. But a mother always thinks they smell sweet. As opposed to a baby that's taking formula. Once your baby starts taking formula, or any other food for that matter, then that bowel movement looks a little bit different. It's a little bit more formed, it's a little darker in color, and it has an odor to it, okay? So there's another plug for breastfeeding, is that they don't smell quite as bad, okay? And our babies usually pee and poop pretty much right after they eat. So we put them to the breast and nurse them, and we're gonna expect to have a wet and or poopy diaper right away. Okay, and so we want to check those. We want to make sure the baby has peed and pooped before he goes home, just to make sure that that system is working well. If we do any kind of intervention, like if we did a circumcision on the baby boy, we want to make sure that he pees after that to make sure that we haven't damaged anything at all. And then otherwise, the number of wet diapers are a good clue to us that the baby's taking in enough fluid, that he's getting enough to eat. The last thing that I'm going to talk about is the color of the baby's skin in terms of jaundice. We talked about color generally, consistent with the genetic background. At first, the baby has pink centrally, but he has cyanosis on his hands and feet, acrocyanosis. That's because when those lungs first fill with air and he has to get rid of all that fluid, then he starts sending oxygenated blood. And of course, the hands and the feet are not as important as the heart and the brain. So they're the last to get that oxygen, okay? The other thing in terms of skin color that we look at is jaundice. Remember we talked about a baby that might have a cephalohematoma? Well, all those red blood cells are gonna have to be broken down. And then they're going to have to be gotten rid of or eliminated from the baby. And his poor little liver is immature. And it can keep up for a while, and then it kind of gets behind a little bit. And if the liver gets behind in breaking down those red blood cells, then we have an increased amount of bilirubin in the blood. And what happens is our baby starts looking yellow. Okay? Jaundice goes cephalocaudal, and then it goes away in the opposite direction. Okay? So if I see a baby that's yellow everywhere, I'm worried, okay? If I see a baby that's very yellow in the first 24 hours, I'm very worried because that's abnormal. That's what we call pathologic jaundice. Remember in your anatomy and physiology, something that is pathologic is bad, okay? And so there's something going on there with a blood incompatibility or some other thing, and so we need to worry about that. But physiologic jaundice is normal. And it just means that on day 2 or 3, my baby gets a slight yellow tint because he's just a little behind in getting rid of all of that bilirubin. I can blanch the skin here. I can look at the sclera. I can look at the gums, okay? If the baby looks fairly yellow to me and it looks increasingly yellow, we have what's called we call it a bili flash. There's a fancy name for it, a transcutaneous something or other, okay? But we put it on the baby's skin and it gives us a flash of what the bilirubin level might be, and then we can call a provider and actually get a serum bilirubin level and see if we need to do something, okay? So physiologic jaundice is okay, pathologic jaundice is not okay. Either way, to get rid of that bilirubin, we need a baby peeing and pooping, which means we need him eating. So the more he'll go to the breast or the more he'll eat, the better off we're going to be. And if he really has a significant amount of jaundice, if it gets really bad, if the levels get too high, we can actually have jaundice on the brain, which is permanent disability. That's called kernicterus. And so we would put our baby under ultraviolet lights so that to help him break down that bilirubin. Okay, so I'm going to look at my cards and see if I got everything. You can see that I talked about some of those reflexes as we went along head to toe. Again, if you don't have a baby and you're just using a pillow, just say, here's my baby's head and I'm palpating the head. Just talk me through it, okay? The whole purpose of this is to see that you have practiced some and that you know what you're doing, okay? Make sure that your note cards are easy to read, okay? And that they make sense to you.